thank you.
Good. My name is Barb. I'm a nurse, and I'll be continuing to assess your vital signs. I was in earlier. I don't know if you remember me.
I do, thank you.
What I'm going to do now is check your blood pressure, and your name is?
Islyn Warner.
Great, Islyn, and I'll just check your armband and make sure, and your birth date is?
10/18/79.
Great, okay. Islyn, I'm just going to sit down here next to you. Have you had your blood pressure checked before?
I have, but not for a little while.
All right. Have you been exercising recently, or
No.
smoking, or anything like that? No, it might affect your blood pressure. All right, what I'm going to do is just wrap this blood pressure cuff snugly around your arm. Now, what I want to do is I want to make sure that I have a cuff that fits properly. So the cuff should be about 2/3 of the length of the upper arm, and it should wrap snugly around the arm so that the Velcro attaches easily. So when I inflate the cuff, it won't be pulling apart. What I'm going to do now, Islyn, is just find your brachial pulse. So that's right up here. The brachial pulse is on the inner aspect, or the medial aspect of the upper arm. If you flex the arm and feel that tendon there, you want to go just inside or medial to the tendon, and you should be able to feel the brachial pulse there. That's where I'll place my stethoscope when I go to listen to her blood pressure. First, I'm going to do this as a two-step method. So I want to find her radial pulse, which will be down here in her wrist. Okay, and I'm just going to let your arm rest so you're comfortable. And I'm going to, while I'm checking or palpating the radial pulse, I'm going to go ahead and inflate the cuff until I no longer feel the pulse, and I'll note that number. So I'm watching the sphygmomanometer. I've closed the valve. Typically, with these valves, if you turn to the right or clockwise, it's closed. If you turn to the left or counterclockwise, it's open or loosened. So I want to turn to the right clockwise right now. I'm going to go ahead and pump this ball. So I inflate the cuff while I'm palpating her radial pulse, feeling or noting when I no longer feel the radial pulse. And I'm not feeling it at about 100, between 100 and 110. So now what I want to do is deflate that cuff, let Islyn rest for about a minute, and I will then take my stethoscope, place it in my ears, and I'll go ahead and make sure that I have the diaphragm side. Some books will tell you to use the bell side. I'm going to use the diaphragm side. It's a matter of personal preference and what you're hearing best with. I think most nurses typically use the diaphragm side of the stethoscope for listening to blood pressure. I'm going to again palpate that brachial artery to make sure I have the right location to place my stethoscope, and I'm going to tuck it right over the brachial artery. Now what I typically do is just hold the stethoscope snugly against the arm by putting my other fingers behind the elbow and my thumb over the top of the stethoscope. That gets a good seal with the diaphragm against the skin. Now, what I'm going to do is, again, close the valve on the bulb. So I'll turn it clockwise, and I'm going to watch the numbers, and this time I'm going to pump up to about 20 to 30 millimeters of mercury above where I no longer felt her pulse. So I'm going to go up to about 130. And then I'm going to release the valve very slowly and listen as the cuff deflates. What I'm listening for initially is when I hear the very first sound, and then the sounds will change a little bit as the blood pressure, as the needle falls, as the the cuff deflates. And what I will note again is that if there's a change in sound from a distinct tapping to a very muffled tapping sound, and then again when I hear nothing at all. So I'm going to go ahead and inflate the cuff now up to about 130 or 140. Slowly release. Okay. And I'll, again, note those numbers. Where I first heard the tapping sound, that would be her systolic. There may be a gap between the first sound, the tapping sound, and subsequent tapping sounds. That would be called an auscultatory gap. So you want to be sure that you get the cuff inflated enough, the number high enough, or the sphygmomanometer needle high enough that you're going to not miss that first beat. And then you may have an auscultatory gap, particularly if someone has hypertension. But that's not a typical finding. And then, again, you want to notice either when the tapping sound changes from a very distinct tapping to a muffled tapping, or when it goes away. And that would be the diastolic that you would record. We typically only record 2 sounds, although there are more of those carot cough sounds. We typically record when we first begin hearing it, and then again when it either changes to a very muffled sound or when it disappears. And that's how we would assess her blood pressure. I'm going to go document those findings now, Iselin. Thank you.
Thank you.
Everything seems to be fine.
Thank you.
Mhm.